Good afternoon from Miami Beach. Right here, this is Dr. John Bennett broadcasting for the Neurosurgical TV channel. Today we have our Africa Grand Rounds, and we have the pleasure of having Marco Meloni doing a couple of talks, one a didactic lecture on valves and shunts, and then he's going to talk a little bit about how this coronavirus affects his daily life as a neurosurgeon in North Italy. But first, let's meet the panel. Hello, Zolo.
Hello, Dr. Ben. Hello, everyone. I am Zolo Ivan. I'm a CTA medical student from Cameroon, and it's a pleasure to be here. I'm a member of the Association of Future African Neurosurgeons.
Welcome, Zolo. Welcome, Zolo. Musindo.
Hello, I'm Augusto Musindo, resident of neurosurgery in Maputo Central Hospital in Mozambique.
Okay, welcome. A frequent contributor, as is Zolo. Welcome. And let's see, we have a couple of panelists here. Nyango, are you there? And Dawin, could you please introduce yourself? Possibly. Go ahead. Go ahead. I know some connection's not great. Dawin, are you there? Okay, he's not. Okay, Marco, thank you very much for taking the time, and it's all yours.
Okay, thank you, John. Thank you to all my good friends of African young neurosurgeon to invite me here. I put share. Okay. Okay. John? Okay. Yeah, perfect presentation.
Okay.
John.
Yeah, there you go. It's perfect. Perfect.
Okay, perfect.
Yeah.
So in this panel, I'm going to talk about a bit of history. Then we go to the present, and then we open a window into the future of a common technique used in neurosurgery, that is the ventricular shunt. So a little bit of history before. When we talk about ventricular shunt, we necessarily talk about hydrocephalus. Hydrocephalus was first described by Hippocrates in 400 before Christ. And the term means, from Greek ancient language, water, hydro, and head, so cephalus, so literally water into the head. In the following centuries, this pathology was described also by Galenus, by Leonardo da Vinci. We hear the beautiful drawing, Leonardo, of the ventricular system, and we go to the description by the anatomist, Italian anatomist Pacchioni, of the arachnoidal perforation. As every one of you know, are the first connection between anatomy and the physiology, because they are the site of reabsorption of CSF. And we conclude with a beautiful drawing of here Vitius. It is an extract from the Yazargi microneurosurgery. These authors injected Berlin blue color into the cistern, and they got a beautiful picture of the subarachnoidal space and of the cisternal and subarachnoidal system. Very beautiful. At the same time of developing of the hydrocephalus knowledge, many attempts were done to understand how to care the hydrocephalus. The first attempt were to reduce the head, so push the head. You can figure out what's where the result. Absolutely a failure. We need to wait until the 18th century when a doctor, French doctor, Claude Lecat, created the first shunt. It was a silver needle that punctured the ventricle, and withdraw CSF. Obviously, this technique was a failure, even if more logical than push the head, because it was a problem of infection and the withdrawal was not regulated. So these poor babies died within a few days. In the following century, many authors attempted to improve the technique, like Cocker, that elaborated the puncture by pre-coronal way, is a landmark that every young neurosurgeon needs to know, because it is currently the landmark used for external ventricular drainage insertion. Other authors, like Turkey, elaborate a ventricular cisternal shunt, still used in some selected cases. And we go to other techniques like the endoscopically guided choroid plexus destruction, now obsolete, but in papilloma of choroidal plexus, the posterior ventriculostomy, and an anterior ventriculostomy. You can see here the beautiful drawing by Scarf and Stokey that describe the anterior ventriculostomy, and other authors like Pausch 95 elaborated the first description of ventricular peritoneal shunt. Anyway, all these authors had some problem with this technique, because is highlighted by Nelson and Spitz. These authors say that if adequate absorption of CSF fluid can be secured more uniformly by this procedure in the future, it will seem to be a method which most closely reestablish normal physiology. So the problem was to drain more closer to the normal physiology. So it was needed what? A valve. In fact, Nelson and Spitz in 1949 elaborated the first valve with a two-ball system and insert reservoir. This is the drawing of this valve, and this is the technique of implant with a catheter in the ventricle, the valve with a subcutaneous pump, and the distal catheter into the superior vena cava, so a ventricular atrial shunt. And this time, the follow-up was more satisfying than the first shunt by clinical cut. In fact, this had a satisfying result during 2 years and a half. So definitely an improvement. But the revolution in the valve technology was reached by Alter valve, the Spitz Alter valve. This is the modern valve, first implanted on March 1956. Alter was not a doctor, but an engineer. An engineer to attempt to save his son's life. This is a picture of Alter and his son. His son was born with hydrocephalus. He was dying. So he attempted to build a new valve. He was able to do that in just 2 or 3 weeks, and this is the first Alter valve. This is a revolutionary valve. Why? Because it's a double-layer silicone valve. You can see here this valve with a shell of silicone, and silicone is a revolution. Why? Because it's a more biologically suitable, so the inflammatory reaction are less than in the other material, and the silicone reduces the possibility of clot, of CSF clot, so to occlusion of the valve. So since this valve, many problems were solved, but there was still a problem to solve. And this the problem was faced with the second generation valve. The problem was the hyperdrainage problem. So how to solve this? By adjustable valve, by self-adjustable valve, also known as variable resistance valves, by antisiphoning system, and by gravitational valve. The adjustable valves, this is the first adjustable valve created, but it has a problem. It needed a screwdriver to regulate, so it needed a new operation, so not very comfortable. And we need to wait for the 1973 first prototype of magnetic valve with a percutaneous adjustable, so the valve most common used today. Other attempts were done to create a self-adjustable valves, and this is the first one created by in 1973. A sensor, you can see here the picture, a sensor connected to the valve, and this sensor in the subarachnoid space can check what the pressure there is into the subarachnoid space, and so by a system with the ball cone, reduce or increase the resistance. Also created by Hakim in 1973, this is the commercially available self-adjustable valve, also known as Orbi Sigma valve. And the antisiphoning system was another improvement of this valve. The antisiphoning system is very simple. This is normally open with the patient in flat position. You can see here the catheter. This is the reservoir, and this is the diaphragm of the reservoir. When the patient stands up, that's what's happened. The reservoir filling with CSF, the pressure push down the diaphragm, reducing the radius, and so increasing the resistance. That's the concept of antisiphoning system. Also created by, in 1973, a very prolific year. And we finally conclude with the gravitational valve. Gravitational valves are very simple in terms of mechanical. This is an example of a Cordy-Hakim lumbar with a gravitational system. There is an entry point and an outflow point with a constant resistance and a variable resistance. This is the patient in vertical position, and this is the status of the valve. In horizontal position, what's happened? That's cause gravity, this 4 ball move up, and so if this resistance is constant, this resistance is less. So in a patient in horizontal position, reduce the resistance, and so the flow keep constant. So we saw the past of the shunt with improvement since the first drainage of Claude-Nicolas-Lecat, and we came to the modern valve. So the question is, what's the next? In these years, when we got the smartphone, the smart card, we can also start to talk about smart shunt. Smart shunt, conceptually, what is? It's an implantable system, including hardware and algorithm, that can regulate the CSF flowing on multiple parameters feedback. So what consists in? Consists in this component, a detector that can check the intracranial pressure, the CSF flow rate, and the patient's position. A CSF flow control, so a pump or valve moved by an actuator, so the shell to isolate the electrical component from the body, obviously a source, so a battery, and a communication system, a system like the DBS, where the doctor externally can check the status and take out data out the parameter monitored by the valve. shunt, ECP, CSF flow rate, passive position, and other. Currently, we just have a prototype. There is not yet a commercial available smart shunt. About this prototype, we got some description, but no more. Why? Because the company like Medtronic, Codman, obviously need to keep a secret for commercial purpose. So we can just say that we know about the first smart shunt description in 1988. We know about other prototypes like the Medtronic prototypes with a schedule pre-programmed and feedback control. And we know about some prototype created by a university group like the Leonard group that use an acceleration detector that estimate, just figure out the patient position and activity. So when the patient's COG, and as every one of you know, COG can create a tube squeezer effect in a patient with ventricular shunt. This system is able to see the patient is COGing, so reduce this effect, improving the quality of drainage. In a review of literature, I found also a description of a prototype of smart shunt that used the microelectromechanical system to detect a shunt occlusion. It was elaborated by Thomas and a co-worker by the New Jersey Institute of Technology in 2016. And this is the system, because it's a prototype, not for implantable use. He uses a sensor. How does it work? It's very interesting, so pay attention. This is a graphic with where a proximal occlusion in a ventricular catheter was detected by the sensor at this way. The sensor see at the time 1 there is a reducing of the flow, of the velocity of CSF. In a second time, there is an even more reduction of this flow. So, because the occlusion of a catheter usually happen in a gradual way, is able to tell us, creating a graphic, how long time is needed because this ventricular catheter gonna be occluded in a dramatic way, so in the red zone. So we are able to know this catheter is going to be occluded before the patients came in the red zone, means the patients came in the emergency department with acute hydrocephalus. And the same things happen for the peritoneal cavity catheter. The detector checked there is an increase of pressure because the catheter is reduced like radius at the time 1. In a time 2, this pressure increase. So again, the sensor is able to tell us the time needed for a complete occlusion of the system, and the patients came in red zone. So still, again, we are able to do something before the patients came in emergency department with acute hydrocephalus. So, question. Why there is not yet a commercially available valve? The reason are the power source. We need to have a power source for this smart shunt. And we need to decide if we want to create a smart shunt with a continuous or random monitoring, because continuous monitoring, of course, gonna give us more data, but need more power. A random monitoring use less power, but we miss some data. Magnetic resonance suitability, of course, with a large electronical device, amount of electronical device, there could be some problem of magnetic resonance suitability, but this is the less problem. The most important problem is another, the battery size. If the smart shunt need to monitor so many data, of course need more power, and so a larger battery. So we need to see again to recreate the surgical technique, because it is not conceivable to implant a large battery here. We need to implant a large battery in another side of the body, but not in the subgaleal layer. So, and another, of course, another problem is the cost. So we go to the conclusion. I can see we did a long way since the first attempt to care by pressure of the head, the hydrocephalus, to the closed Nicolale cut drainage, to the modern valve, and to the concept of smart shunt that we hope in the future going to be available for human use. So long way need to be done again, but as somebody already told, where we're going, we don't need road.
Hey, Doc, we better back up. We don't have enough road to get up to 88. Roads? Well, we're going, we don't need roads.
Thank you.
Back to the future. that was a surprise to see that creep in there. But thanks a lot. Thanks a lot, Marco. A big surprise. That's great. Yeah, let me get you off the screen. Let me get you off the share there, Marco. Okay, excellent presentation, and I'd like to open it up to the panelists for any comments or questions on what Marco talked about. Okay, the floor is open. Come on, guys.
Hello, Dr. Marco. Thank you very much for the presentation. It was a wonderful presentation. When you said you had only 6 slides, I was like, personally, I was thinking of 6 slides. It was more than 6 slides. Thank you very much for the presentation, and thank you so much for the presentation. Quite explicit, quite futuristic, and yeah, I heard it to us from the past, like from the basis to where we are and where we're intending to go, where there are no roads. Thank you so much, Dr. Marco. Thank you.
Thank you, Joseph.
Thank you, Marco. I have a question. Does a general neurosurgeon put in valves, or is that like a pediatric neurosurgeon? Or is there something that any neurosurgeon can do?
To be pediatric neurosurgeon?
Yeah.
Be pediatric neurosurgeon, just the neurosurgeon. General surgeon, general pediatric surgeon usually do appendicitis, bowel surgery, but neurosurgery, pediatrician neurosurgery should be done by the neurosurgeon. Is absolutely necessary, because the anatomy is the same. Of course, the pathology is quite different from human, but the concept of embryology, brain embryology, is a neurosurgical matter.
Yeah, I realize that. In certain parts of the world, general surgeons, like in Africa, I think they put in valves, right? A general surgeon, do they do that in certain parts of the world, or they generally refer to a city to have that done?
In Africa, you mean?
Is that done? Oh, okay. Does a general surgeon ever put a valve in third world countries, say, or is that just a neurosurgeon?
No, it's just a neurosurgeon.
Oh, okay. Okay, now amongst neurosurgeons, is that usually the work of any neurosurgeon, or do they refer to a pediatric neurosurgeon?
We refer to the pediatric. Of course, for the commonest pathology, like to be brain hemorrhage, every neurosurgeon must be able to take care. But for more for other pathology that don't consist in an emergency, like would be medulloblastoma, for example, we usually refer to a more specialized pediatric neurosurgeon.
Okay, thank you.
You're welcome.
Thank you. Thank you. Any more comments or questions? We have some new people here. Hello, Marvin. How are you? Could you please introduce yourself? I need to unmute you there, Marvin. Go ahead, Marvin.
Hi, Bennett. I'm Marvin, first year postgraduate neurosurgery in Ivory Coast.
Okay, welcome. Welcome.
Thank you. Sorry, I joined the panel late.
Okay, no problem. Things will get better. You know, the bandwidth is sometimes weak, but that's okay. It's going to get better and better and better. And certainly people with connections that aren't very good, Marco, they can text questions in the panel there. If you guys have a text, if you want to text a question and your bandwidth is not great, like DeWin, for example, DeWin is there. He's nice enough to come, but I don't think he's strong enough bandwidth to have a picture. Are you there, DeWin? You can just text any comments or questions. Stuart, I think your bandwidth is pretty good, right? Here's your...
Oh, I'm here, Doc.
Oh, go ahead. Go ahead.
Okay, I'm so happy to be here. Hi, everyone. So I'm Darwin Chimba, medical student from Copperbelt University, Zambia. Thank you so much, Dr. Meloni, for the presentation. It was so great. Thank you.
Thanks for coming, DeWin. Thank you very much. And do you see the way DeWin's handling it? He's not putting his camera on, so he saves bandwidth, Marco. He can participate in this webinar, can see your presentation, and can ask questions. So you're not limited by having poor bandwidth. You can try it. You might be able to interact with just the audio. Okay, Arsene, are you there? Can you hear me, Arsene? Because I know you participated in the past. Perhaps not. Joanna, you're back from a presentation yesterday. Where was that from? Geez, Marco, my mind's going.
Hello, John. I'm here.
Okay, great. Just introduce yourself, please.
Hello, everyone. My name is Arsene Daniel. I'm from the Democratic Republic of Congo. I'm a medical student in 7 years, and I'm aspiring a neurosurgeon. So I would like to thank Dr. Marco Meloni for his great presentation about the future of the how to treat the hydrocephalus. So about the ventricular shunt, that is a very great presentation. So we are waiting for the presentation about how they are doing neurosurgery in this context of coronavirus.
Yeah, we're looking forward to that. We'll wrap this talk up first. It's an important topic, valves. Musindo, any comments for Marco? Musindo, can you hear me okay?
Yeah, I can hear you.
Okay, good.
Yes, I would like to know what is the best, how we can do to choose the best shunt put in the hydrocephalus.
Is
a difficult question, right?
$1 million question, I guess.
Yeah.
Yeah, usually there is no some parameters to understand what's the best of valves. Is a question of experience of the single neurosurgeon. Usually, I prefer to use adjustable valves because in my experience, I also used some valve with self-adjustable or gravitational. But as probably you saw when I talk about smart shunt, there are other parameters like the cogging. Sometimes also is very. It could be very. I can say not so important, but the stipsis in a patient with ventricular peritoneal shunt could be sometimes dramatic. I saw some patients with symptoms of occlusion of valves, and then when I asked them, how long time don't you go to empty your bowel? They said, well, about 1 week. Oh my God, that's the reason. So I prefer use it to adjustable valve because I am able to implant the valve, first of all, knowing the pressure of patient, because in normal pressure hydrocephalus, that's the most common pathology where I got implant. First of all, I perform some tests measuring the pressure of CSF, measuring the resistance where I inject fluid into the subarachnoidal space, and with tap tests. So using all these parameters of pressure, of resistance, I am able to understand if is a patient with high resistance, and so he needs a valve with 200 millimeters. If a patient has not so big resistance, injection fluid into subarachnoid space, I know probably he needs a less resistance valve, so 160. So preferable is my personal experience, and in my department we do a lot of normal pressure hydrocephalus pathology. We prefer to use the adjustable valve because using the percutaneous system is quite simple. You implant the valve, you check a CT scan after 10 days, and you check how the patient is feeling and how the TAC CT scan is going. So you see there is a hyper drainage, no problem. Just a few minutes, take the patients, put the scan, and regulate again the valve. So preferable my adjustable valve. In the future, smart shunt, I hope.
You know, there's a question from the audience.
There's one.
Go ahead.
Okay, there's a question from Dr. De Miguel Lozano. I hope I pronounced the name well. So he's asking, Dr. Marco is asking your experience with the use of delta valves versus strata type valve. What is your experience?
Delta valves.
Delta valves. I don't know. Miguel, could you explain what that is? Can you talk, Miguel? I don't know. Maybe he's not be able to talk. Go ahead, Miguel. Can you elaborate on your question?
A moment.
Miguel, can you hear me? I don't know. He's asking about delta valves. Has anyone heard of that? Perhaps you haven't, Marco. Have you heard of a delta valve, Marco?
No, actually never.
Okay.
One moment. Probably I know in another way, but it's not a valve I got experience.
Yeah, I imagine different countries have different brand names, right?
Yeah, there are a lot of commercially available valve, of course.
Right.
I use the Akin valve, the Codman valve, and Sofisa valve. I use a magnetic system to without needed to head X-ray. I don't have experience with this type of valve. I'm sorry.
But generally, Marco, I know that surgeons find one or two pieces of equipment they like and they stick with that pretty well, and they don't learn about new brands and stuff like that. I imagine it's like that. You can't expect to know about every country's brand name. So, okay, comments or questions, Stefan?
Yes,
go ahead.
I have a question. I have a question, Dr. Marco. So, assuming you have a patient and after placement of a shunt, the patient develops fever, like in let's say the 24 hours following the placement of the shunt, and there is apparently no other cause of the fever. What could be what could be the major what could be the major causes of fever in the following 24 hours of placement of a shunt?
Sorry, can you repeat, Zola? The audio was.
I say, should in case there's placement of a shunt in a patient, like let's say a baby of let's say 1 year old, yes, and within 24 hours he develops fever, high grade fever, 39, 40 years. What could be the causes of the fever in such a case 24 hours following the surgery?
Okay. Did you hear that, Marco?
He developed fever, you mean?
Yeah, fever. Youngster, 1 year old, I believe.
Well, of course, you need to see what's the origin of this fever, because a fever can be done by several reasons. If in a little baby, this baby developed fever and developed symptom of occlusion, so you need to first of all externalize the implants. That's the best thing you can do. If there is a occlusion, you can verify in a very simple way. Usually there is a reservoir in the valve. You punch with a needle the reservoir, disinfect, punch with a needle, and occluding the catheter, you're able to see if there is occlusion in the proximal or in the distal catheter. If there is occlusion, there is fever, and the baby is developing symptoms of occlusion and also of meningitis, externalize. Or anyway, if you have some doubts, just don't lost time, because development ventriculitis is a very, very hard pathology to take care. So if you have any doubts, obviously reason, not the baby came to your attention, fever, okay, it's got a valve, externalize. No, wait. See fever, see there is a symptom of occlusion, just in operating room, externalize, and take some CSF for a microbiological examination, and then start with vancomycin intrathecal.
Okay, good, thank you.
Thank you very much, doctor.
Okay, any more comments or questions for Marco before we move on to the next presentation?
Yeah, I have some questions.
Go ahead.
Yeah. Well, the first question is the common practice in Cameroon concerning valve placement is when you put a valve, you don't remove it until there's a problem, an obstruction, fever. Well, I would like if there's time length for the valve to be in. How many years should we leave a valve in place? Can we change even if there isn't any malfunction or obstruction? That's the first question. The second is how do we deal with ventriculitis if we have removed the valve?
Sorry, the audio was a little bit trouble. are you able to write down the question? Because
Yeah, can you write that down, please?
sorry.
No problem. It's a limitation of this platform, but we can deal with it. We can deal with it. Could you? I could hear part of most of, but obviously the different treatments in different parts of the world, right, Marco? I think what he was referring to is that they don't take the shunt out until they really have to in Zambia. Maybe I understood
In
it correctly.
Cameroon.
I'm sorry, in Cameroon, I'm sorry. Do neurosurgeons tend to be more conservative about removing shunts in an area where they don't have a lot of hydrocephalus equipment or shunts? Or do you take it out at the first sign of infection?
Is a question for me, John? Or?
Yes. Like, are you hesitant to take out a shunt? You have to make absolutely sure you have to take it out to replace it or cure the infection?
In a patient with acute infection, you need to save his life to remove the shunt.
Okay, so that's the first thing you do is take it out.
Okay, absolutely. Take it out or
Okay.
put an external ventricular drainage, because you need still to drain because you cannot also create an acute hydrocephalus. So you need to have an external ventricular drainage, and to drain the fluid, the CSF fluid, and also to inject antibiotic, to do intrathecal therapy, and also to examine the microbiological, the CSF fluid in a long distance and see if CSF is clean. If CSF is clean, there is no growing of a battery of the microbiological is clean. Now you can implant again the shunt.
Okay, very good. Okay, very good.
Wait,
Well,
the question of Marvin.
okay, any questions or comments? Any more before we close? Okay, Marco, thank you very much for an excellent presentation. And now we'll move on to the next presentation, which is an excellent topic, of course, nowadays. And I thank Marco for taking the time to tell us about it. But it's basically coronavirus in an epicenter by a practicing neurosurgeon, what his life is like. And we were talking before, and Marco said he's not an expert on coronavirus, neither am I, and most of the panelists. But he can tell us about what his life is like now. So Marco, away you go.
Okay. Okay, just a moment. Okay, just a few slides to have a line of talking.
Okay.
Okay, presentation. Okay, moment here.
Beautiful. I didn't realize you made a presentation. Wow. Thank you.
Oh, you're welcome. No, just to say 6 slides. As probably everyone of you know, is a situation of a pandemic. So we got a spreading of this coronavirus pneumonia in a large part of the world, also in the United States, but Italy, and in particular my region, the Lombardia and Milan, are the most involved. It's absolutely a dramatic situation, but we're doing the best. So in this period, of course, for the neurosurgeon is a dramatic situation as well. Why? First of all, because we cannot guarantee the elective surgery. So patients with problem that like lumbar discal hernia or pathology that can wait need to be postponed. And so is mean that we have a loss of practice as well for us. And also there is a centralization of neurosurgery. So it means that the big center of neurosurgery are organized to take care of the most part of emergency neurosurgery, and the little hospital with neurosurgery are moved to stop the most part of surgical procedures and to have more space for patients with coronavirus infection. So I'll tell about our situation in my town. I can resume the situation in this way. There is a loss of neurosurgical activities, is mean a loss of practice. So the question I did to myself was how to obviate of this loss. My answer is this: some suggestion to keep myself and I hope ourselves in training. Meeting online, so keep studying, keep to studying neurosurgery by book, by meeting online, like our meeting. Use of 3D models to study. So not just a book. Probably every one of you already know it is absolutely better, but use a 3D model, like my cranial is a very cheaper. You just pay a few dozen of dollars and you have a 3D model to study. So it's more closer to the daily activity neurosurgery. And third, keep in touch with research. So continue to update yourself by PubMed, by journal. And another thing, surgical training at home. What I like to say, the desk microsurgery is there is an example. The most easy example is the chicken wing. I bought some iron. There is a picture. It's taken from a beautiful book I suggest you is Getting Ready for Brain Tumor Surgery by Sabel, and he explained how to do desk microsurgery. So get training at home or in a little laboratory. Personally, I bought some iron like this and some needle for microsurgery available online. And I use or a microscope, a desk microscope, or loops. You use a chicken wing. Chicken wing has in this site an artery, a very slim artery. So you can take this, cut, and attempt to do a suture of the vessel. This is a work I did myself at home. This is the chicken wing open with the artery. I cut the artery. I put a little paper to have a better visual. And I attempt to suture the artery. That's a way to keep in training myself, because neurosurgery is also like a sport activity. You need to be to keep in training, because we start, of course, but we need also practice. So to conclude very, very fast, always remember that we are neurosurgeons, but we also And first of all, we are doctor. So don't tell yourself, I'm a neurosurgeon, so I'm not involved in this pandemic. If you are a doctor, you got the responsibility to take care, if you request, of patient with coronavirus. So you're a doctor, first of all, then you're a neurosurgeon. Okay, so keep in training, study, exercise, keep in training at home, but where you're in department and it is requested to you to take care of a patient with coronavirus infection, do your best, because first of all, you're a doctor and then you're a neurosurgeon. And another suggestion is continue to look at the future, because I hope in a short future, this pandemic will solve. So think about what you're doing in the future as a neurosurgeon, as career, as practice. And also, and most of all, think that andrà tutto bene. In Italian language means everything gonna be all right.
Oh, good. Okay, andrà tutto. That's great. Thanks a lot, Marco. And now, how is it affecting your life? I mean, we talked before, and you said you can't leave the city. You can't really. Can you tell us about the restrictions that you have now?
Well, I can describe my daily activity. I have some shift in a coronavirus department, so I'm working to take care of patients with coronavirus.
Oh, okay. So part of your practice is treating patients with coronavirus.
Yeah, correct.
Oh, wow.
Activity is very reduced in terms of neurosurgery, but
Okay.
I continue to training myself. So at home, as you saw, I do practice with use of a microscope. Is a desk microscope where I put the chicken wing. I use this iron to do microneurosurgery. I study from books like Roton to continue keeping training with neuroanatomy. That's the basis of every neurosurgeon.
Right.
So I continue to study, to update myself, so to read about, update about peripheral neurosurgery. That's my main field of activity. I tend to take care of myself also by physics, using my little gym corner. I cannot go to the gym because the gym are closed.
Yeah, here too.
I got. You can see probably my gym here.
Yeah.
A table, a weight. So I tend to take care of myself too, because a neurosurgeon, physically active, is a neurosurgeon that work well. That's my personal opinion.
Yeah.
Psychologically, I attempt to be strong. Talk with you, talk with all you guys, and talk about neurosurgery is something that make me live. So
yeah, well, it's great. It's great. And you know, I think there's a phrase in English called cabin fever. It's when you're locked up in a place. Maybe you have the same term in Italian. But I don't think cabin fever is going to affect a lot of doctors, you know, having to stay indoors, because we're used to studying and we're used to being indoors and we're used to working for long hours. So for me, I don't know about you, it's not that difficult for me to do that, because we can, as doctors, we can always study. As students, we can always use more time to study. So although it's a tough time, it's in some ways it's not so bad for us.
Oh yeah, for surgeon is very hard. Cabin fever is actually
without operating. Yeah, that must be a little different.
Yeah, correct. In fact, do practice, study, and figure out also operation. Check. Just remember that by YouTube, by Neurosurgical TV, absolutely, and online, you have available many video of a surgical operation, of a neurosurgery. So it's not like operate, of course, it's another thing, but it helps to remember who are you. And what's the future is a reservoir to you when all this pandemic gonna be all right.
Well, you know, I'm surprised. Any comments or questions from the panelists? I'm kind of hogging the air. Any more questions? Stefan, Joanna, Dawen? Go ahead, Zolo.
Yes. I have a question, Dr. Marco. Okay, Dr. Marco, is it possible for you to tell us what are the preventive measures you take, for example, for you not to be infected? Because you're working with a patient every day.
We're losing it. We're losing the sound.
Anyway, I hear that.
And what do you do practically?
Okay. Well, first of all,
yes.
When I get out, I get out home. I use a mask. I show you. It's a surgical.
Yeah, it's a special type of mask, right? Because you guys have probably heard about this. Some masks are not very good at all, and some are pretty good.
Actually, to get out, I use this. It's a very simple mask. It's not protective against the virus, but it's protective for people I meet.
For carriers, it's better, right?
Exactly. Because I work in a hospital, I at more risk. So I wanna defend the other people I meet, even if I meet few people.
Right.
When I and the other mask are able to like the FP3 mask, the 3M mask, are able to avoid to take the virus. When you expire, if you got the virus, you take out the virus. So it's not good to use this mask to get out on. To get out on is very useful, and you need when you're into the department with people infected, because people infected cannot transmit you the virus if you use the FP3 mask. But if you got coronavirus and you wear this mask, you spit the virus outside. So to get out, use a simple mask. Keep the people have more than 1 meter of distance. Don't put the head, your hand, sorry, in the mouth, or squeezing the eyes. And when you, if possible, use a glover. I prefer use a glover to touch, if I go in the store, to touch the box.
Public places, yeah.
Yeah, and when you get out, you back on, always clean your hands. Clean right. 20 seconds at least.
Yeah.
And if you got opportunity, also use this. A moment, I tell you.
Yeah, you know, it's said, and you guys can remark this, but soap is very effective at killing the virus. I don't know if you can hear me, Marco.
Another thing I use is this gel.
So soap is very effective against the virus. Soap, just regular soap.
Yeah, soap, absolutely. And if you outside, you don't have water to wash your hand and you need to wash, you can use this. It's a gel. It's infection gel. You put here. 2 drops are good, and so fine like this. Mm-hmm. It's not like like wash your hand by soap, but is kill the most part of virus in your hand. Doesn't mean that you put the gel and then you can touch your mouth, not at all. Mm-hmm. But to reduce the virus, so it's better to have one of these. If you go outside, I always got this. I send some of these bottles to my siblings and my girlfriend. So It's better to use that.
Mhm.
When you're into the hospital, if you come into the department with coronavirus, you got another sort of protection, more restrictive. You got the FP3 mask, you got the how you can say,
hat.
protection,
The gown, the hat and the gown. Is
the
that?
gown.
Yeah. Okay.
You got the protection for the chest, abdomen, and legs, double glower, and it's a hat. It's very uncomfortable. Probably you see here, I have got a red nose because the mask for 6 hours,
Mhm.
but is protective. So it's not an easy situation at all. But if you're strong enough, you keep going and respect the rules, the risk is more and more less.
Yeah, I'm seeing more neurosurgeons reach out to use video platforms. Not a tremendous amount, but there's definitely an uptick in interest. How about as far as a physician? I know some physicians cover a couple of hospitals when they operate. Is that kind of limited? Doctors just stay in one hospital and that's it? Do you know what I mean? They travel around to a couple different hospitals in a city like Milan. They might go from one to the other. Are they restricted in that way also?
Well, it has happened in Milan, above all. Here we got just one hospital, so we're restricted to my hospital. We don't move. In Milan, where there's also my girlfriend's, sometimes she need to move by department or by hospital. Sometimes happen, and
Okay.
the government also request offer for 300 doctor compensation. Compensation to come in other structure where is needed to take care of patients with coronavirus. Yes, these are reorganization period.
Yeah, well, you know, it's funny. There's different penetrations in different parts of the world. With this platform, we speak with neurosurgeons all over the world. South America and Africa have not really been hit hard yet. And you guys all know about that, right? Solo and Arsene and Darwin. Hasn't really got to Africa yet, but I guess a lot of people feel it will come eventually to all parts of the world.
Yeah. Actually, yes, the virus is already present in all the continents, all the continents. But what is interesting is that in Africa, it does not have the same burden like in Europe and the other continents. So there are some speculations about the reasons why the burden is not that high. So for now, I have not come across something like a scientific pertinent reason why it is not the burden is not that high in Africa. Perhaps the immunity of some Africans might be have been used to some many viruses, and so maybe, but I've not come across like a scientific explanation about why the burden is not that important in Africa. What is being done in Cameroon is that the government came out with, I think, a set of 13 measures where the main measures are like to try to reduce the spread of the virus because we registered cases. I think we are at 27 cases already, 24, 27 cases. So the
What
no more
Probably Zulo is happened because the virus was born in China. So we got a relationship, commercial, very intensive with by China and Europe, and I think also by China and United States, I guess, John. So the opportunity of contact of infection are more higher than African country, I guess, and also the movement of people are very intensive in Europe. So the opportunity for coronavirus to spread was more higher than Africa.
You know, I think in warm climates, it does not spread as quickly. I think it's been proven that coronavirus does not. And they actually, some scientists feel that when the weather gets warmer with summer, that it's going to decrease by that factor alone, the warm weather. It's a factor on the spread of the disease. Okay, any more comments or questions from, this is a topic we could go on forever, Marco. I know that everyone's, I mean, obviously, but I'm surprised to hear that they're recruiting the neurosurgeons to be doctors to see corona patients.
Of course, we are assisted by internal medicine.
Right, they help you questions and stuff.
But if there is an acute situation, like patients don't breathe very well, or need a therapy, every doctor, even neurosurgeon, even urologist, has a basic medicine formation, so is able to do that. Of course, if I have to decide what's the best therapy to care the coronavirus, to stop the coronavirus, I don't have this competence.
Right.
So I refer to the infection colleague, consultant, or the internal medicine doctor. But if I have the patient with short breathing, I have the instrument culturally to do my best. Then we can only leave alone these patients.
Okay, can you describe a typical presentation of a patient with coronavirus? I mean, they have a fever. What have you seen actually patients with active coronavirus?
Yeah.
Okay, could you describe them, please? Their typical presentation?
Fever, dyspnea, short breath.
Short of breath, even the young people?
Unfortunately, the less part are young, but also young people 40 years old. Most part are people with a compromise, a breathing compromise.
Okay, like COPD.
Exactly, chronic pulmonary disease, already overweight, or
diabetes,
heart problem. Of course, these people are very more prone to have a worsening, also death caused coronavirus.
Right.
So the symptoms are very intensive.
Mm-hmm.
In young people, we got some cases with presentation, fever, dyspnea, short breathing, and cough. Usually the typical patient with pulmonitis of coronavirus. When then you check the arterious
blood gas.
Exactly. Usually you see a oxygen pressure that is 60 millimeters Hg, so it's very short.
Yeah.
And a chest X-ray, you see an interstitial pneumopathy. Interstitial pneumopathy is the landmark of coronavirus because you got an interstitial pneumopathy.
Okay.
So if you got all these parameters, the patient is a high probability coronavirus. So check the test for coronavirus immediately, isolate the patients, and if the patient is with a bad blood gas analysis parameters, clinical uncompensated situation, you need to put in ward, assisted with CPAP, or even by endotracheal intubation.
Right.
If the symptoms worse and the patient is in RDS, respiratory distress symptom.
Yeah.
Go
ahead.
If patient is in a well condition, it means that blood gas is 100 or even more symptoms are very subliminal, you check the test. Then if the patient is positive, you can discharge home, but the patient need to stay isolated at home for
quarantine. Yeah, quarantine.
There is a patrol control. So if these patients get out home, is arrested. So arrested and put in the ward forcibly. So that's our flow charting.
Yeah, it's the same thing with tuberculosis in this country. If you don't get treatment, you get arrested if you don't take your medicine. Now it's supportive treatment essentially. There's no medication to give patients, right? At this point, you basically support them to support the respiration and treat the fever, right?
Yeah, of course, we don't know a lot of this virus yet.
Right.
So we know the most part came to our attention with these symptoms. Some people say this virus is also neurotrophic, so could give some encephalitis. Actually, I haven't seen any one of this. But we know we're learning from this virus. We're understanding day after day how this virus behavior.
Yeah, there's certainly no shortage of information on the internet about the coronavirus. There's a wealth of information, and it seems like pretty good information. So that a lot of people can spend their time now at home researching coronavirus if they want.
Oh, wow.
Yeah, unfortunately, that disease has put us in the house. But again, it's a good time for a physician to bone up on his craft, on his science. But certainly, go ahead, Mark. Go ahead, Marco.
No, absolutely. I think that also the research for a vaccine is speeding up, and also the research for a therapy. We in Italy we got in experimentation drugs usually used for arthritis rheumatoidis is the Plaquenil. And it seems to work well and reduce the symptoms of RDS. So it's able to help these people to overcome the infection. We're experimenting these pharmacs, the Plaquenil, and we hope this work.
Right. Yeah. Right. There's been some reports of the malaria, I guess, chloroquine, combined with a erythromycin type of medication, that it doesn't kill the virus. Like, there's not medicines that do really, but it slows down the course of a coronavirus infection. There's been some reports, and the FDA, I think, is kind of trying to fast track the chloroquine and the erythromycin type of drug for accepted treatment. For the FDA is frantic. They're looking everywhere, and they're fast tracking anything that's possible. Genetic companies are saying we'll do free genetic profiles, and we'll research this virus with all the equipment that they have. These chemical companies on analyzing. Of course, they're working overtime to analyze how the virus works, what's the best place to hit it at for medications or whatever. So that the private sector too it's nice to see them involved with coming to a definitive treatment for this. And
yeah.
like you said, I think that something will happen within the next year. I think I'm just guessing. It's a kind of an educated guess, but it's not a for sure thing.
Yeah.
So any more comments or questions from anybody? Okay, Marco, thank you very much. Yeah, double the didactic lecture and the coronavirus. Wow. So we hope things get
And-
better. We hope things get better for you, and I hope things get better for the rest of the world. One way to deal with this is to become very educated about what's going on and everything, and that'll help. So thanks, everybody. I'll end this formally. I'm going to stick around. So goodbye from Miami Beach.